view on the diagnostics and treatment of childhood relapsed ALL and the, let's say, standard of care, the current knowledge, and also the future directions or perspectives of this disease. Since we are not a huge crowd of people, I want to invite you to interrupt me, to have questions all the time, whenever you want, and even if you want to have a discussion, because it's an opportunity for you if you want, and if not, I just go on with my slides. So please take this chance if you want. Yeah. This is a list of potential conflicts of interest. For me, it's always an interesting slide because it shows that people in my position have many contacts to pharmaceutical companies, and I also always want to underline that this is a very important activity because we are consulting the companies which are producing interesting new drugs for our children, and we need to interact with them to make sure that the drug development is in the right direction and in the best interest of the kids. Usually pharmaceutical companies don't have a huge interest to develop drugs in kids because the market is small, the doses are small, and the risk is high, so side effects may persist the lifelong. So they don't want to have this topic if ever possible. We need to make sure that, and nevertheless, the drugs are developed for kids, and we need to consult them how best to integrate these drugs, and not to do a plan, maybe even with the authorities, that is not compatible with our treatment strategies. This is something we have seen already a couple of times. So if we are not sitting in these advisory boards, they come up with a plan which is fully unrealistic and spend a couple of million euros and then have to close the program because it's not feasible. That's why, for me, this is a very important activity. Topics of the talk is definition, pathogenesis, diagnostics, prognostic factors, treatment, summary, and perspectives. Here you see the results of primary disease treatment, an example of the ALL-BFM trials, but there are many other examples all over the world. This shows that the event-free survival could be improved over the years in the different trials, and here are the relapse incidences. But what I want to say that better than treating relapse ALL is to preventing relapse ALL, and all the efforts should be done to treat the children with ALL best and not to have relapses. On the other side, you should not overtreat these kids at primary disease with the aim to avoid relapses, because on the other hand, you expose many kids to a lot of toxicity that would not need this, for maybe very few where you can then spare relapse of the kids. So that's you need to find the right balance, and certainly new drugs, new immunotherapeutics are very feasible, maybe to be more effective but even less toxic. 15% relapses, it's more or less what we have to deal with at the moment. So how do relapses occur? So first, how is ALL actually how does it work? And there are some interesting works that show that there are first chromosomal events, even pre-birth, so prenatal. There can be a chromosomal event that can produce something like a pre-leukemic clone, and after birth there can be another genetic event that leads then to a leukemia. And a classical example for this is telomere 1 positive leukemias, where there's a strong evidence that there are pre-leukemic clones that already exist at birth and that are not yet malignant, but they can transfer to a malignant clone if there are other events. This shows the heterogeneity of acute lymphoblastic leukemia. It's even not a very updated picture. It's from 2011, but it's getting more and more heterogeneous. But you see two big complexes: it's the hyperdiploid leukemia and the ETV6 ranks 1, and this makes even half of the leukemias, of acute lymphoblastic leukemias. And as you know, these are These are genetic subtypes that have a good prognosis, and this also explains why children with ALL have a good prognosis, because of most of them have good prognostic genetic subtype. Here there are some TLL genetic features, BCR-ABL, very small one, MLL, there's also the infants and some others. Also, here you can see the distribution of these subtypes by age, and as I said already, here you have in infants, you have the MLL positive leukemias, which are associated with a poor prognosis, and then you have these big bars of hyperdiploid and ET46 ranks 1, and these are also the children with the best prognosis with in the younger age, like 2 to 5 to 6 years. They have, most of them, a good prognosis. And here you see schematically a cell with a different intracellular signal transduction pathways. And we know that in addition to these primary genetic lesions that I've just shown, there are additional genetic alterations that affect this signal transduction pathways and usually lead to a proliferation signals of the cells when these pathways are activated. Just some examples is the RAS pathway. RAS-MAP pathway is quite frequently mutated. It's an activating mutation, and there are other pathways like the JAK-STAT pathway and the TP53 pathways that all interfere into the cell proliferation and differentiation, and they let's say support for the development of the leukemia. And these are pathways that you can target with targeted drugs. And this is maybe something of the newer developments that we also try, in addition to very conventional chemotherapy, which is quite untargeted, to implement also targeted treatments into treatment of ALL, if ever possible. But so development is not quite advanced here. This is a result of our ILRADS BFM 2002 study, and from the kids we have treated is a number of candidate genes that we have investigated, which could, for example, show that 1/3 of the patients have the CDKN2A and B deletion. So this is also a pathway where you can cyclin kinase inhibitors may be an effective tools that could interfere here, but there are other genetic lesions that are remarkable here. Again, the ETV6 ranks 1, 15%. At relapse, TP53 is very important, and some others. Down syndrome is also here, a small number of patients. And this is an example what such a genetic alteration can, what the influence can be on prognosis. Here this is a TP53 mutation or deletion, so we say alteration, and you can see that patients, so this is a chromosome 17, P13, and here you can see all the loci of the mutations that have been identified. And anyways, any alteration in this gene led to a much inferior prognosis in childhood relapsed ALL. And this was not only true for the total group, but also for standard risk patients. So a standard risk patient, so with quite a good prognosis, with chemotherapy and transplantation with a TP53 alteration, had a really bad prognosis. And we've seen that around 12% of the patients had such a genetic lesion, and 4 of the patients that we could detect had even a germline mutation, so Li-Fraumeni syndrome. So it was not only the ALL, so they had a broader problem than just the ALL. This is I just want to briefly say that we think that leukemias that this is a clonal disease, because it actually derives from one cell. One cell is dividing, and so these cells are all clonal, but they are not identical. So within the clonality, you have the heteroclonality, because these cells have all defect genetic, let's say, machinery, and the further division of these cells and proliferation leads to more genetic defects, and so these cells are actually deriving from one clone, so they are clonal, but they are also heteroclonal, and this is in particular true at relapse, where we see heteroclonality, and we see maybe one clone that was only a subclone at diagnosis comes up at relapse as a major clone, and so on. So you have many different ways that some clones proliferate and others disappear, and so that's why you have a clonality and a heteroclonality in one. So we have ALL's proliferation of immature lymphatic cells, genetic alterations, sometimes with a sequential evolution, selection mechanisms, heteroclonality at relapse, numeric alterations, mutations, and activations of intercellular signal transduction pathways. ALL relapse diagnostics, it's actually the same as primary disease diagnostics. So you have the cytology, the classical, which I consider very important. Many people think that cytology is already old-fashioned. You don't need this. You have much better, much preciser tools. But very often you have to take the diagnosis on cytology to have the first decisions, and then after a couple of maybe days you get all the other important results as immunophenotyping, cytogenetics, molecular genetics, and gene expression profiling. So all the other more sophisticated methods just to type the cell, the immunophenotype, and also the genetic background. Now, the prognostic factors that we are using nowadays, we use very simple factors. So one is the time point of relapse. It's still the most important risk factors, very early and late time point. Then we use the site of relapse, and so isolated bone marrow relapse always has a worse prognosis compared to extramedullary relapse. And then we have a new feature, which is the high-risk genetics. And high-risk genetics is, for example, the TP53 alteration, where you have seen, irrespectively of the standard prognostic factors, this is a very poor prognostic feature. And there are a couple of them. It's the TP53 alteration, hypodiploidy, T1-19-17-19 translocation, and MLLA4 translocation. And all these have event-free survival rates of less than 20%, even with intensive chemotherapy and with transplantation. So we can conclude that for the high-risk genetic subgroup, the conventional approach is not acceptable because the outcome is so poor. And for the others, you see standard risk patients have a 70% event-free survival rates, and high-risk patients of 40%. So standard risk, we can say this is already a very good result, and we should not, let's say, we should keep this good level. High risk, we need to improve, and very high risk, it's actually nearly experimental, because whatever we do is not effective. The general treatment strategies is in standard risk patients, combination chemotherapy and stem cell transplantation only in those patients with MRD poor response, and I will show you why that is the case. High risk is combination chemotherapy in B-cell precursor plus blinatumomab. In the meantime, this has been shown, and I also will show you the data, and then all of them will get stem cell transplantation. Very high-risk patients, they are getting already experimental induction, in this case B-cell precursor leukemias with inotuzumab. They get an individualized consolidation, and then they will get CAR T cells or allo stem cell transplantation. And the patients need local treatment if applicable. So for CNS relapse, for example, CNS irradiation. For testicular relapse, orchiectomy or testicular irradiation. So there's always also the need for local treatment if applicable. So in standard risk relapse, the chemotherapy we are using, let's say in Europe, in other continents it's a little bit others, we use 4-drug induction with the ALLR3 mitoxantrone approach, which has been developed in the UK, or multi-drug short course treatment, ALREDS BFM 2002, which has been developed more in the German-speaking countries, and we have compared these in the in-trial 2010 trial. Then the consolidation is also multi-drug continuous or short course chemotherapy, and this has also been addressed in the in-trial 2010 trial. Maintenance chemotherapy plus minus reinduction pulses for those with a good MRD response. And here you can see the ALREDS BFM chemotherapy blocks just as an example, just to show that we use all the chemotherapeutics that we also use at primary disease. So we just repeat the treatment, a little bit different combination, but anyways, you see this kind of backbones that are always present, and then other drugs that rotate or are changed in the different courses here. This is also a historical picture just showing that we could define standard risk patients and very high risk patients. So these are only late extramedullary relapses, and these are patients with very early bone marrow relapses and TLL relapses. And in this analysis, stem cell transplantation has been censored. And you can easily see that these patients have a very poor outcome, and they really need an intensification, which is, for the time being, stem cell transplantation. So there's no doubt that these patients need to be intensified. But in these patients, so the intermediate risk patients, S2 patients, with late bone marrow relapse and early late combined relapse, it was something like an intermediate outcome, and it was not so clear whether we need to transplant these patients. There was the MRD tool, MRD after induction, where we could show that patients with an MRD good response had a very good outcome with chemotherapy, and those with an MRD poor response, so more than 10 to the minus 3 after induction, had a very poor outcome, and we could conclude that these patients behave like high-risk patients and need an allogeneic stem cell transplantation, whereas the patient with MRD good response can be well cured with conventional chemotherapy. And this has been also integrated in the 2002 trial, ALREDS BFM 2002, where we have did a randomization, which I don't want to address now, but I want to show you that patients with an MRD diagnostic after induction here, they were allocated to stem cell transplantation if they had an MRD poor response, or they got the continuation and maintenance therapy if they had an MRD good response, just as a consequence of the data we have seen before. And this led to the following result. Here you can see that the 2002 trial had a general outcome which was much better than the trials before in the ALREDS BFM trials. So this step was mainly done due to the correct allocation of intermediate risk patients to stem cell transplantation. And just to compare the UK trial, which has been conducted in the same time, let's say, where they randomized mitoxantrone versus idarubicin on the basis of a 4-drug induction, and the mitoxantrone arm had a much better outcome, and you can see here that the outcome is very comparable to the ALREDS BFM 2002, but what is really inferior is the idarubicin arm. That's really the important finding here. This is just to show you the effect of the correct transplantation of the MRD poor response patient. So this was the old trial where you could see the MRD good responders and the poor responders that had not been transplanted. Here you see the 2002 trial where we transplanted the MRD poor responders, and we could lift up the event-free survival to the same level than in the MRD poor responders. So this is a really, really well validated indication for allogeneic stem cell transplantation. MRD is not only important after induction, but also pre-transplantation. There have been several investigations that MRD patients with a higher MRD pre-transplantation had a lower event-free survival and a higher relapse rate post-transplant than those with an MRD good response. So it's also always the goal to bring a patient into a good remission before transplantation. In particular, in ALL, in AML, maybe it's not as important as here, but this is very important. And then, I said already that the stem cell transplantation is a very important part of the relapse treatment, and 2/3 of the patients have an indication for allogeneic stem cell transplantation. So any high-risk relapse patients and half of the standard risk patients that have an MRD poor response. So we have a lot of transplantations, and you all are aware of the Forum trial, where a big consortium, not only a European but international consortium led by Chris Peters, investigated whether we can get rid of TBI, because TBI is very toxic for children. Everybody knows this. It's toxic for the growth, for the hormones, for many tissues, and also has high risk for secondary malignancies. So everyone wanted to get rid of TBI, and we tried to randomize TBI versus chemotherapy, and chemotherapy was allowed to use triosulfan-based or busulfan-based regimen, and you can see that the TBI event-free survival was much better than the chemotherapy arms, and this was overall survival and event-free survival, and this was already apparent in an interim analysis, so the trial had to be stopped, and nowadays TBI has to be considered as standard of care because of this really huge difference of event-free survival. And this is, nobody's happy with it, but we all know that if 25% event-free survival benefit, we cannot, so we have to counterbalance with all the side effects. And so the consensus is, yes, we need to give TBI unless we don't have something better. Very, very remarkable is that treatment-related mortality was very low in this trial, in this huge international trial, and was below 10% in all the arms, but the TBI arm was even lower than the chemotherapy arm, which was actually a surprise because everybody thought TBI is more toxic, but the toxicity of TBI is seemingly not so the acute toxicity, but more the late toxicity. And the Forum trial was not only for relapsed ALL, it was also for primary ALL. And this is in this Christmas tree plot here, you can see that for the patient in second remission for relapse, TBI was also beneficial, and also for bone marrow relapse and combined relapse and so on. So for all these patients, the TBI was the better factor, the better condition regimen. So that's why we also for relapses have to say, yes, TBI is the standard of care, unfortunately. Now I want to come to the Intrial consortium, because we all have understood that we cannot perform trials in relapsed ALL in just one small country, even in one bigger country, because it's rare, it's only 15%. And so if we come together on a European basis, European level, and even with some non-European countries, we can augment the patient numbers to, in standard risk, to maximum 200 per year, and in high risk to 100 per year. That was at least the calculation. In reality, it was somehow lower, but anyways, we could plan trials where we can do randomized studies in a reasonable time frame of 4 to 5 years. That was the idea of this international consortium. And the first big trial we started was the Intrial SR 2010, where we randomized exactly these two arms that I've shown already, the German IRADS-BFM and the UK ALLR3 arm. It was because these arms were quite established in different countries on a different level, and we wanted to establish all these arms in all countries and wanted to compare them and see whether there's one or the other arm better as a standard of care, and which can then serve as a backbone for further drug development, because in the future we certainly want to replace toxic chemotherapy with more targeted immunotherapy. So the arm A is the IRADS-BFM 2002 arm, and arm B is the ALLR3 arm. So we randomized both, and then we had a second randomization with this consolidation plus minus apratusimab. Apratusimab is a CD22-directed monoclonal antibody, a very conventional one. And this was a drug which was, at that time when we started, was available. The company was interested, so the company Immunomedics supported the trial. But then this drug, which had been developed for rheumatological diseases, failed a big phase 3 study, and the company stopped the production, stopped this also our trial. So after a 2/3 of recruitment, we did not get any further support from the company, but it was, let's say, good enough. And I will show you the results that we could conclude that this drug is really not adding anything positive to the chemotherapy, and that it's not worth to continue even this. And the first randomization has been stopped in August 2020, so we are now in the late follow-up period, and we can show already results. Here just the recruitment numbers by country. You see there are big countries and small countries and different recruitment rates. The biggest recruitments come from Germany, from France, and from Italy, but all the other countries also really making a huge effort to bring in all the patients they have, and so we are very happy that all these countries participate, and that we come at the end to a total number of 695 patients, which is a really huge trial for relapsed ALL. Here you can see the outcome of the first randomization, and you can see that both arms really do equally. So we can say that the chemotherapy, if you give intensive conventional chemotherapy, you get a good outcome in standardized patients, and it's not so exact content of the chemo doesn't seem to be so important. But there are some interesting findings that we wanted to show in a subgroup analysis, for which the trial was not powered, but anyways, everybody does subgroup analysis. We could show that patients with isolated CNS relapse did much better in arm A than arm B, which is not so surprising, because the arm A has more high-dose methotrexate, more dexamethasone, is maybe you can say is a little bit more CNS directed. And what we can also show that the arm B was better in preventing subsequent bone marrow relapses. So here in arm A you have more bone marrow relapses than in arm B. This is a light blue, and this is even significant. So you can see the arm A is isolated CNS relapse is more effective in arm A, but arm B can better prevent bone marrow relapse. So these are some findings that we thought were remarkable in subgroup analysis. We have also a high-risk trial which is investigating the R3 backbone plus minus bortezomib, a proteasome inhibitor. And this is ongoing, so we cannot show you the results because it's still ongoing and recruiting. But remarkably, we have had here an investigational window, because the endpoint of this trial was remission rate after induction. So after this endpoint, we could introduce something else, and we opened this to an investigational window where you could investigate more here, and this has been taken up by Amgen to investigate blinatumomab. So this is ongoing, and this is the Amgen Blina trial, which has been done in this investigational window. So the in-trial trial was a preceding treatment, and after 2 consolidation cycles, the Amgen trial, the 215 study came into the game, and they randomized the 3rd conventional chemotherapy cycle versus blinatumomab monotreatment, and then all patients have been transplanted. So just, is blina better than conventional chemotherapy as a bridge to transplant in high-risk patients? And the outcome of this trial was remarkable, because here, also in this trial, we had to stop the trial at an interim analysis, because the blina arm had such a better outcome, event-free survival outcome, that the DSMB said we need to stop the trial. And this was not only event-free survival, but also in overall survival. So blina proved to be a much better bridge to transplant strategy than just a conventional chemotherapy course. And here you can see also in this kind of forestry plot that this is true in all subgroups, also in patients with, so irrespectively of age, of the MRD level before the inclusion, and also high-risk patients who could benefit from blina, and also patients with very early relapse could benefit from blina. And the toxicity is just to summarize here, the blina arm was much less toxic than the chemo arm, which is not, so maybe you all have probably already some experience with blinatumomab, and you know that this is quite easy and it's not as toxic as chemotherapy. At the same time, the COG has done a very interesting trial where they replaced not only one treatment cycle, but the whole treatment, the whole consolidation treatment in high-risk patients and intermediate risk patients, so all patients that had a transplant indication, not only high risk, but also standard risk with MRD poor response, which they call intermediate risk patients. And they also stopped the trial preterm because they saw a better event-free survival of the patients, although this was borderline not significant. They saw a much better MRD clearance in the blina arms and a much better toxicity profile and a better bridge to transplant, so a better, higher rate of transplanted patients in the blina arm, that they said better efficacy, less toxicity, better transplantation rates. We cannot continue this trial, they stopped the trial. Although this was not yet significant, so the primary endpoint had not been achieved, which was a problem for the publication because they had to mention all the time it's not significant, we did not achieve our primary endpoint, but at the end everybody understands that it's difficult, ethically difficult to continue this trial when you have this data. But they also did something interesting because they also did a comparable trial in standard risk patients, so on those that had an MRD good response. And here they did one replacement step, so they replaced block 3 with blina and two add-on strategies. So they added blina on top of the chemotherapy. So there was a mixture, and the outcome was here. So this was a significantly better outcome in the blina arm, but in a subgroup analysis of patients with isolated extramedullary relapse, blina did not lead to an improvement of outcome, but it was not inferior. And again, they could show that toxicity was always much better in the blina arm compared to the chemotherapy arm. So that's quite a lot of data in favor of blina, and this motivates us to integrate it into different strategies. And you also know that it's already investigated in frontline treatment because of these really favorable data. Another important drug that we are very interested in is inotuzumab ozogamicin. Is a CD22-directed monoclonal antibody. Actually, this one is more or less eprotuzumab, but here there's a toxin linked to the antibody, which is called calicamycin, which is in particular very lymphotoxic. And this is after binding to the CD22 antigen internalized into the cells and leads to a cell death. So the toxin which is internalized leads to cell death. And there's an ITCC 059 trial investigating inotuzumab in children with relapsed ALL, so relapsed refractory ALL, and there were a couple of patients included, and importantly, they achieved relapsed refractory, so a very poor prognosis patient group achieved 80% remission rate, and of those, 85% MR negative. So it was a very, very interesting outcome of this single drug in this patient group. So we considered this as very important. And then it's important to know that Ino is actually well tolerated. It has some liver toxicity, but in particular, it has a quite high risk for veno-occlusive disease post-transplantation. Here in this small group, there was no patient with VOD post-transplant, but in the phase 2 trial, they've seen already VODs post-transplant, and VOD, as you know, is a life-threatening complication after transplantation that needs to be always considered when you speak about inotuzumab, and it's also for us because we want to integrate it quite systematically into the ALL relapse trials. We have to really be very careful and very closely monitor the VOD rates and also the fatalities linked to VOD. Here's the phase 2 trial I mentioned here, just the same remission rates and the really great MRD negativity. It's at least as good as CAR T cells, but it's not persisting. So you get the good remission, but then the drug effect is over and the patients will relapse if you don't consolidate this effect. Whereas with CARs, if you have a remission, you have a good chance that there's persistent CAR effect, and that's why you cannot compare it, although the remission rates are really comparable. VOD here, you had 3 VODs within 9 patients post-transplant, so that's already a relevant number. That's what I said. But anyways, this drug is very attractive because it can induce really good remissions, can debulk leukemia, and so we consider it as a drug that is in particular feasible for remission induction. And this is also good because then you have quite a distance to the transplant. You have to give consolidation treatment in between. So for us, it's good to have a remission induction, then a consolidation, then hopefully the transplant a little bit away from the drug and maybe less VOD problems. CAR T cell strategy, I think there are a lot of talks about it, so very briefly only just showing you the Eliana results of this Kymriah Tisagen Leukocyte, which is filed for pediatric patients, and also relapsed refractory B-cell precursor leukemia showed very interesting event-free survival in the range of 50%, which is very good, and it's always difficult to understand how this is in relation to other strategies in this difficult patient group. So there's one interesting paper by Ma et al., and they compared the Tisagen Leukocyte with other trials that have been performed in the same indication, and they did in something interesting, because you cannot, if you have published data, you cannot modify the published data, but you can modify your case data. So they have tried to adapt the patient selection of the TISA group to the published patient cohort and try to adapt something. So they did always one adaptation and one without double adaptation, but they could show in both strategies, here this is matched and unmatched, that the Tisagen Leukocyte had always a much better outcome than the alternative trials. For example, this was our Blina trial, phase 1-2, then there was a clofarabine trial, then there was a chemo trial, and another chemo trial with different chemo combinations, and they also looked to the second transplant data, which had been published by Kuhlen et al., but they did not, due to technical reasons, they did not show this kind of data, but it was also superior than second transplant. So this is a very important strategy that we have to consider and have to integrate in our strategies as well. I want to show you now the INFORM strategy. INFORM strategy is a molecular genetic platform that allows to classify leukemias and to identify targets and to consult for targeted therapy in patients that do have no other good chance, that do not respond, and that are, and also for T-ALL patients, because all these nice immunotherapeutics, they are good for B-cell precursor, but not for T-ALL. So for T-ALL, we have always a big question mark what we can do, and so we bring all patients with first relapse of T-ALL into this workflow. This has been done. This is a German approach, actually for. So that you just bring the material, they do all the screening methods, and there's a tumor board, and then there are many specialists participating in the tumor board, but also the treating physicians, and then they bring a recommendation. And here you can say that this is mostly for many other entities, and the hematological entities are very small, and the ALL is just a small part of this whole project. So it's for solid tumors much more feasible, and for ALL it's also maybe interesting, but the problem is that ALL has such a rapid dynamics that many of these patients did not get the targeted treatment due to different reasons. Just here, this 30 patients just showing there's a couple of them were TLL. In 97% of the patients, we could identify a targetable target. And in 35% of the patients, this target was of high priority. So high priority means that the specialists think that this target is treatable and this treatment should be effective. So it's actually a good news that if you have such a tumor board, there is a chance to find a good target and even a chance to treat it. Whether the treatment is beneficial or not is a different question, but at least it's worth to try these kind of boards, and we will establish this in different. So there's a federal board which is being established in the Interval Consortium, the ILTB board, which has been implemented by the PMC, with the aim to bring in these informations into the clinical decision making of patients with refractory relapsed leukemia. And here I just have a table of signal transduction inhibitor trials, small molecule trials that are ongoing. So bortezomib is already something that I've mentioned. Bortezomib is not targeted actually, but it's also a small molecule that is effective in this kind of cell proliferation and cell differentiation strategy. Carfilzomib is also a proteasome inhibitor, and selumetinib is a MEK inhibitor. There's a phase 1/2 ongoing, an ITCC trial. Venetoclax is also maybe not so targeted, but also a small molecule that can add to restore a deficient deficient apoptosis cycle in the cell, and ponatinib as an advanced phase B-cell TKI. This is in European setting, but in the US there are more trials. Ruxolitinib, a JAK-STAT inhibitor, palbociclib, ribociclib is a CDK inhibitor, and menin inhibitor. So there are other trials ongoing, and many of them are also transatlantic approaches, because these patients are so rare that you need even transatlantic cooperation to get at least a minimum of. Yeah. Yeah, at what time we introduce this, that's an absolutely good question, because that's the problem of these patients. So in these trials, the inclusion is mostly relapsed refractory leukemia. So many of them have a relapse post-transplantation, and then they are open for these kind of trials. And these trials mostly need a single drug phase, because you need single drug toxicity. And then these trials frequently have also a combination phase where you combine it with chemotherapy, because many of these small molecules only act if you have already an impact on the cell, and then they improve the cell response to the chemotherapy. And so you do this as a reinduction before you do something else, maybe before you retransplant or before you go to CARs. And this is in these formal trials, but in the tumor board, where you have not a trial, where you just have a personalized treatment, you can add this also to a conventional chemotherapy pre-transplant. And we also frequently give some of these drugs post-transplantation when we know transplantation will lead to a very poor outcome, and the risk of subsequent relapse is extremely high. There are some drugs that you can well give after transplantation. One good result is venetoclax. There's already quite a couple of data around, in particular in AML, but also in ALL, that this improves the graft versus leukemia effect in a way that, because most of these effects, they end up in apoptosis of the leukemic cells. And let's say the simple idea of venetoclax is that it just restores in a way the deficient apoptosis of the cells, and that's why it may be synergistic with any anti-leukemic impact, also with the graft versus leukemia. And so that's what we do in the individual, but it's a difficult question, and yeah, it's also not fully solved. This is just an example of a study which is ongoing that I mentioned, selumetinib, a MEK inhibitor. And you see our KRAS and NRAS mutations that we have seen in our RATS BFM 2002 study. And there are 15% of the patients that had a mutation, and these mutations are activating that, which means the pathways are activated and they lead to a proliferation of the cells, and so the selumetinib is blocking this activated pathway. And there are also mouse data that this is effective, and this trial is ongoing, and we will see whether this is really a helpful drug or not. Now I come to the strategy of our next trial, in trial BCP 2020, where we integrate many of these findings that I've just shown. And first, the very high-risk patients, as I said, they have a poor induction rate, they have a poor remission rate, they have a poor event-free survival rate. So we go for this with a completely experimental approach. They all get at the moment inotuzumab, or they can get inotuzumab, they can be included into the ITCC 059 trial in a separate arm. So any very high-risk patients can be sent to a participating center, and then they get an individualized consolidation. Then they can get a CD19 CAR T-cell approach. This is not licensed here, so this needs to be something like an experimental drug, and this is something we want to develop in the next Intrial trial, and Franco Locatelli is leading this kind of treatment. And the standard risk, high risk patients with bone marrow relapse and those with isolated extramedullary relapse, they will get in induction randomization, inotuzumab, as you have seen, very good induction drug versus standard of care, ALLR3. Then they get one consolidation block, and then we randomize the consolidation with blinatumomab, replacing several chemotherapy elements, and then they get maintenance therapy. These are the MRD good responders. And there was a discussion, should we really randomize blina, or should we give everybody the first blina, because we know blina is good. But the EMA did not accept this, they rejected this, and we have to know that even the conventional arm has a very good outcome in the range of 70% event-free survival. So that's why the standard of care approach is a very reasonable approach, and that's why we accepted also this kind of design. Patients with a pure response, or those high-risk patients, they all get blina as a bridge to transplant. This has already been shown in the 215 trial, so this is already standard of care and is also licensed for this indication. So this is paid by the health insurances, and then they will be transplanted. And here in the high-risk patients, there's an investigational window, and this will be used by Pfizer, and Pfizer will do a formal licensing trial for inotuzumab and child relapse ALL, same as here, and they will do such a trial to give us the opportunity to get to have a licensing of this drug also in our pediatric indications. In extramedullary patients, we give the arm A, so the IRATS BFM arm, because it has shown to be better effective. And those patients nevertheless get one course of blina before they are transplanted or before they get further chemotherapy. This is something we have implemented. And the investigational arm, this looks like this. This is the Pfizer view, so inotuzumab versus R3, and then they will be shifted to the Intrial trial, so it's just an induction trial. They just look for remission rates, and then the patients are further treated in the Intrial trial, and they get transplantation. Okay, and then what do we do with the TALL? As I said, TALL, there's no immunotherapy, and so we want to investigate in TALL, in particular, this kind of signal transduction inhibitor approaches. And so there's a trial which will be sponsored by the PMC, by Michel Swan, and is also is developed by André Lissat and Paco from PMC. And there are 4 arms at the moment that have been that are planned. One generic arm in patients that don't have a target, and they will get decitabine, venetoclax, and navitoclax. So you see, venetoclax you can give more or less to everybody because you don't need a target. And this is a generic arm, and then the MAC SARC pathway activated patients, they will get dasatinib, venetoclax, dexamethasone, and then the IL-7 receptor JAK-STAT pathway activated patient with activated leukemias, they will get ruxolitinib plus venetoclax, dexamethasone, and the RAS-RAF-MAC pathway activation. So what we've shown before, they get trametinib, dexamethasone, and the chemo backbone. So chemo backbone may be added to these patients, so they will start with a more targeted, low-intensity trial, and then they will add chemotherapy. And this is a very complicated trial, and it's also for a very small number of patients. And probably your countries will be or have been approached for participation, but only in some selected centers. This cannot be opened in every pediatric oncology centers, and then you should please transfer patients to the centers that are open to this trial, because if not, we will never get enough patients for the trial. We will never get any answers for this actually very important proof of principle. Is targeted therapy in relapsed leukemia, does this has an important role or not? So, summary treatment, multi-drug, short course versus continuous chemotherapy is standard risk patients, B-cell precursor with MRD good response, curable with chemo, with MRD poor response, require allo stem cell transplantation, immunotherapeutics in B-cell precursor leukemia and advanced development, for example, blina, inotuzumab, and T-cell leucel. Signal transduction inhibitors, small molecules, are in development for targeted personalized treatment, as you have seen, and Intra is a European platform for development of innovative curative treatment strategies, as you have seen in the last slides. And the perspectives that I've also shown is that we will achieve licensing for inotuzumab in high-risk relapsed ALL, sponsored by Pfizer. We are establishing inotuzumab as induction strategy for standard risk and very high-risk patients. These are academic trials. We want to implement an intensified use of blinatumomab replacement chemotherapy. We want to further optimize transplantation, and there's a discussion about the TBI dose and whether we can modify TBI and also GVHD prophylaxis. So something which is ongoing in the Forum Consortium. Then there's a platform for personalized treatment of patients with relapsed TALL, so the HEME-ICEMOD trial, which is being developed. And there are target decision leukemia expert boards that recommend individual patients for personalized treatment. This is the INFORM, for example, Federal and ILTB, but there are others in Europe that are in place to do this kind of work. And there's an international transatlantic collaboration for developing new compounds that are even transatlantic and that go beyond the European perspective. And with this, I want to close this talk, and I want to thank all the patients and their families that participate in all these trials and that contribute to here, and the teams of the participating centers that have to document, have to do all the formalities, which is very difficult, in the involved study groups, the IBFM, Intrial, COG, ITCC, and all the national groups that are also well organized and that transfer all this huge work into the national real world reality, and also the financial support. And we get a good support, and we are very happy for this from the European Union. We had the 7th framework program for the Intrial 2010 trial, and we get again a European support for the 2020 trial, and that's really, really very helpful. And I thank you for your attendance, and I hope you have some questions to me. Yes.
Sorry, I'm starting all over.
Switch on.
It's on, okay. All the children we have lost after transplants, have you looked into their genetics? Like, what were their genetics, those we lost?
Who relapsed or died?
Died, sorry.
Yeah.
Died.
So I think we did not go this way, but the other way, just to identify specific genetic subgroups and then to see that they die after transplant.
Okay.
So we did this way. So we can say a patient with a TP53 alteration has nearly no chance to survive the whole thing. Mostly they suffer from subsequent relapse and die from the disease. Do you mean more toxicity or more?
Yeah, more toxicity, and also in like when we think about haplotransplants and the genetics that are very dominant in these children. What do you think about haplotransplants?
So haplo is absolutely standard in our transplant regimen. So I did not go deep into the transplant issue because it's a little bit different topic. But yes, haplo. So all the indications we consider for these patients, we also accept haplos, and but we still think that a good matched sibling or unrelated donor is a preferable transplantation. Although there are data mostly from centers, for example Rome, but also others, that show very attractive data from haplos, and you can question yourself whether would not be interesting to compare haplo versus matched unrelated, because haplos are really good, but it's also depending on the experience of a center, and not everybody does haplo. So haplo is absolutely accepted, and it's also part of this here. And I'm not aware in the relapse setting of correlation of treatment-related deaths and genetics, but there are not so many patients dying from so we have like 7% treatment-related deaths. So this is about 50 patients in the whole trial or so. And so it's not a huge number to make big data correlations. But the Forum trial certainly does and did this kind of correlations. And I have to say I'm not aware that there are any genetic features for patients who die from the transplantation. But there are a lot of genetic data on patients that relapse even after good chemo and transplantation due to genetic lesion, which is just makes the leukemia so refractory. Yeah. So this way is, yeah.
Thank you, Anna, for this very comprehensive presentation.
Microphone.
Thank you for this very comprehensive presentation. We really enjoyed it. I think I noticed a slight difference in the treatment of the standard risk relapsing patients in the last study, 2022. Could you please go back to the slide to see for the standard risk patients what is your approach? Oh, sorry. Yeah.
Yes. Okay.
There it is.
Yeah.
I think this is the one, SCB2M. What is the difference between the SCB2 and the SCB2M?
That's a good question. That's a very good question.
I noticed that because I have studied it a lot.
That's a good question. Yeah.
Sorry?
So I have to say, I did not show you all the data because of the time, but in the next resistant disease session, I will show. I will show an update. Yeah, it's in a different place, but it's next one in an hour. I will show an update of the data of the in-trial 2010, and there is some more treatment-related mortality in the arm B. And we can correlate this quite well with this huge high dose RRC of this SCB2, because they give, I would say, 2 times 8 gram, isn't it? 2 times 8. So 8 gram, I think it's, so in 1 week, within a couple of days, 8 gram in another week. So it's a very, very toxic treatment. And everyone knows that this is the most dangerous, let's say, part of this R3, and we wanted to replace this completely with Blina, and we wanted to give everybody Blina and start a randomization only afterwards, because we said actually the COG has already shown the benefit of Blina in standard risk patients, and why should we repeat this trial? But the EMA, we have sent this for scientific advice to the EMA, and they did not accept it. They said, no, you have to randomize. It's the data. It's not robust enough for us to accept this maybe as a filing trial, because if we have a positive result, we want to get access to the drug. So they said, no, you need to randomize. And then we said, okay, if we randomize, we at least need to skip 1 week of RSC just to give only half of it.
Okay,
it's just a decision. It's not controlled, but because of the findings we had.
Okay, this I didn't know. And second question, the study has already started. Is 2020?
No, it's not started.
Yeah, but it is BCP 2020,
yeah,
so we have 2023. And I just wanted to ask, when do you initiate the study?
Yeah, it's good. Yeah, but it's always, if most study groups, they have a year when they want to start, and then they have a year when they start in reality. So I guess this year, we want to start this year.
Yeah.
We are still, it's not so easy. We have 2 big pharmas here in Amgen and Pfizer. And everyone who's something to do with Pfizer knows this is the most complicated company with respect to contracts and so on. This is a nightmare. So we are still in the process of contracting, but very importantly, we got the Horizon call. So we have a basic financing for all the participating countries. And so the goal is to open the trial this year, ideally in summer, but I'm not sure about the negotiations with the companies, and without that, we cannot start.
And when it starts, it will start for all arms, very high risk, standard, high risk?
The very high risk is independent, because the very high risk is already, the INO is already open since 2 years or so.
As an ITCC.
So the ITCC, you can, whenever you have a very high risk patient, you can send them to PMC or to an open center, because they are really lacking patients. And the CD19, it's not yet open, because it's in negotiation with Milteny. It needs to be supported by Milteny, because it will be on the Milteny platform, because the Kymriah is not available for this indication. So we need to do this as a trial. And so this is still not yet ongoing. And with respect to the investigation window, this is quite advanced, because the companies are always quicker than we are. It's the same was with the 215 trial. So they maybe have already approached you, and they are going to open this trial also this summer, I would say.
Yes.
So the things have been signed and so on. So they are quite.
Yes, this
advanced.
is true.
But they have 500 people that are doing nothing else and implementing these trials, and we have 5 or so.
Okay, thank you very much.
Maybe you've already since long time.
In isolated extramedullary relapse, especially for patients with isolated extramedullary CNS relapse. You know, COG showed more CNS relapse in Blina arm, and we know that there are no indication for Blina in many countries for extramedullary relapse.
Yeah, that's a very good question. There are some data that support this, and maybe I can. This is in the COG trial. The patients with CNS, this one here, it was not worse. It was maybe more or less equal, and this was in really standard risk leukemias. And the remarkable outcome here is that both arms are so poor, because in the intra. This is a mistake. This is standard risk patients. These are standard risk patients, and these are so here the CNS also extramedullary relapses. Blina is not really adding a benefit, but it's at least it's less toxic. And there are other data from our trial. Just a moment. From the 215 here. Here you see the extramedullary relapses here. they also benefit from Belina. It's a subgroup analysis in the 205 trial. And there is also in the COG, in the high-risk trial of COG, there are also some benefit. And the data are really not very robust, but we want to investigate this with compared to historical controls. And we think that at least there's no risk, that the data do not show that there's a risk for these patients. And if we get a benefit, we will see in the historical controls, and at least we will spare toxicity. And this is something which at least EMA accepted. And I agree that this indication is not very robust. It's a discussion, but we think we do not do harm. We probably will not lose efficacy. Maybe we will win some, or we will have less toxicity. Yeah?
If I may help, the difference between the two studies is also on the definition criteria. There are some differences between the 215 and the COG study. There are some different definition criteria.
Yeah.
So you can't really match the results so similarly, if I may help in
yes, thanks.
why do you decided to put Belina? Well,
but
if one can add this.
Yeah, I think we have to close because we are after 10. So sorry that we have not another half an hour for discussion. But thank you for being here. And if you have any questions, you can find me in the floors, and I'm happy to answer you anything.